I was honored to present the Phase III NeoADAURA study at ASCO this year, evaluating neoadjuvant osimertinib with chemotherapy, osimertinib monotherapy, or chemotherapy in patients with resectable EGFR-mutant non-small cell lung cancer. The study enrolled patients with stage 2 and 3 non-small cell lung cancer determined to be resectable at baseline, and the randomization was equal between arms. The primary study endpoint was major pathologic response at the time of surgery. By blinded independent review, both osimertinib-containing arms showed a statistically significant improvement in major pathologic response rate compared to chemotherapy. Well, I can say, the toxicity was greater in the combination arm. That's anticipated, right? We would expect toxicity to be more with 2 drugs versus 1, and the profiles were entirely consistent with what we know of the combination from FLAURA2 and other studies. There was only 1 adverse event that precluded surgical resection, so that's actually a pretty amazing number. So who to choose for which approach is not something that this study addressed. I think that's where the art of medicine comes in. We certainly understand that chemotherapy can improve the cure rate in patients with resectable non-small cell lung cancer. So whether to give osimertinib preoperatively and chemo adjuvantly, or to give both together in the front-line setting before surgery is a question we don't have the answer to. So I think at this point we just have to use our judgment about the fitness of the patient. I think it would take a much larger study than we performed to show an overall survival benefit of this approach. What we do see is an early event-free survival advantage. However, that will likely be watered down by the adjuvant prescription across arms to all patients. So this study, I would be surprised if it showed an overall survival outcome. It's actually not a planned endpoint of the study. However, if we had a much larger real-world study, I do imagine that early separation of the curves is going to ultimately translate into clinical benefit. These studies are admittedly difficult to run, and there remains a lot of debate in the field about who needs neoadjuvant therapy and how much. I will admit that while giving osimertinib with or without chemotherapy was much better than chemotherapy alone, I wish we were doing even better, and that our pathologic complete response rates were as good or better than those we see with chemo-IO in wild-type populations. So I hope we can find drugs that truly kill the cancer in the future, but we're still waiting for those novel combinations to exist. I think the hot topics we have moving forward are expanding our arsenal of well-tolerated oral targeted therapies for other oncogene-driven lung cancers. We saw great data presented for EGFR and HER2 targeted therapies as well as KRAS. I also think we're beginning to see the practical implications of using ctDNA to guide therapy, and I look forward to more of that in the future.